So I'm going to talk about fundamentals of intravascular imaging. These are my disclosures. No one learns imaging from a lecture. There's only one way to learn and interpret IVUS or OCT, and that's by looking at images and using them in the cath lab. IVUS or OCT should never be evaluated in a vacuum. It is only one component of the clinical scenario that includes patient information, non-invasive information, coronary angiography, procedure characteristics, and so on. The marketing groups of Abbott and Boston Scientific have commissioned algorithms to aid the novice in performing IVUS-guided PCI. This is Abbott's MLD Max. Of course, you have to ignore the fact that apposition is not a predictor of events. This is Boston's IVUS 123. Again, get rid of malapposition. But these are really graphic marketing stunts. They don't really add much. You should always begin with pre-intervention imaging, where the important parameters are vessel size, lesion length, plaque composition, especially calcification, and minimum lumen area. People think that IVUS and OCT measure differently. Well, that was true in standard definition IVUS, which oversized compared to OCT. But when we now talk about HD IVUS, they measure almost the same. And in my opinion, standard definition IVUS should no longer be used. And when we're dealing with high definition IVUS and OCT, the measurements are effectively identical. When assessing an intermediate lesion that's in a non-left main location, the conventional wisdom is that you should use physiology. However, then came Forza and Flavor. Forza came first, compared FFR versus OCT in assessing intermediate lesions and guiding stent implantation, and the outcome, if anything, was better in the OCT group. Flavor was a similar study randomized to FFR versus IVUS with specific criteria. The outcomes were identical. So my takeaway is that today, when assessing an intermediate lesion with either IVUS or OCT, you can use IVUS or OCT to decide whether or not to stent the lesion, just recognizing that you will place more stents with imaging to decide whether or not to treat than with physiology to decide whether or not to treat, even though the outcomes will be identical. When sizing a stent, you have to understand that the angiogram is misleading. And in general, the angiogram shows that the lumen area is smaller than the IVUS measured lumen area, and the discrepancy is especially important in relatively small vessels. This is even more important when you realize that there is silent plaque in almost 100% of arteries that you are stenting. And so Greg Stone showed years and years ago in a study called the Clout study that you can safely size into the plaque midway into the vessel wall to use a larger stent size to get or larger balloon size to get a better acute result. Now, as I mentioned, you size midway into the vessel wall, but you also identify landing zones. The best landing zones have the largest lumen with the least plaque and the least amount of lipid, and avoiding calcium and muscle bridges. So here is an IVUS pullback. This is distal, this is proximal, largest lumen with the least plaque. Here's an OCT pullback. Again, largest lumen with the least amount of lipid. You don't want to end here, you want to end here. You obviously don't want to end here, you do want to end here. And that gives you length, and sizing midwall gives you size. So the next question becomes, can the EEL be identified and measured at the distal reference? If the answer is yes, you size to the EEL and then you downsize to the nearest stent. And if you can't see the EL, you measure the distal reference lumen and you upsize. Those give you mid-wall stent sizing. And of course, we've already discussed length. Now, in terms of plaque composition, I will not go into these algorithms in detail. I assume that they will be available at least on TCT-MD. And it's a combination of saying, is the plaque within the lumen of the vessel wall? Is it protruding or not protruding? Does it shadow or does it not shadow? For example, if the plaque is in the vessel wall and you have attenuated plaque, it means that it's lipid. If the plaque is in the vessel wall and it shadows, particularly with reverberation, it means that it's calcium. If it doesn't shadow, it means that it's probably fibrotic. Protruding plaque, these are thrombi, and this is a calcified nodule, which I'll talk about later today. Similar algorithms with OCT based upon the presence of attenuation, high attenuation, red thrombus, low attenuation, white thrombus for plaque that's in the lumen, and high attenuation lipid, low attenuation calcium for plaque that's in the vessel wall. Here I've compared normal, lipidic, fibrotic, and calcified plaques by IVUS and OCT. This is normal IVUS, this is normal OCT. This is lipidic IVUS, this is lipidic OCT. This is fibrotic OCT, this is fibrotic IVUS, and this is calcified IVUS and calcified OCT. They both give you a good sense of plaque composition. The one circumstance in which OCT clearly has an advantage is in thrombus detection, this being red thrombus and this being white thrombus. Why do I mention that? Because especially in non-STEMI, at least half the time, you either have no clear culprit or you have multiple potential culprits. And this case example from one of our former fellows, Takashi Kubo, there's a potential culprit in the LAD and the circumflex, and you can see there's an old plaque rupture in the LAD, there's no thrombus, but there's thrombus in the circumflex, identifying this as the culprit lesion. This slide shows you 15 different devices, IVUS and OCT, looking at calcium. And they all have the same configuration. By IVUS, it's shadowing with reverberation and hyperechoic or very bright plaque. By OCT, you can measure calcium thickness, and you have clear demarcation in the interior and exterior border of what is calcified. And again, comparing IVUS and OCT, here is deep calcium by IVUS, deep calcium by OCT, that's kind of hard to tell, superficial calcium by both, concentric calcium by both, eccentric calcium by both, and a calcified nodule also by both. This is a paper that I wrote 25 years ago, and it showed that IVUS detects calcium twice as often as does angiography. There's a certain small false positive rate by angiography, and it isn't until you get 3 or 4 quadrants of calcium that the angiogram becomes even marginally reliable. Akiko and the team repeated this with IVUS, OCT, and angiography with almost the same results as we showed in 1995. There's a slight advantage to IVUS in detecting deep calcium because if there is lipidic on top of deep calcium, OCT will not penetrate to see the calcium, while IVUS does not have that disadvantage. Well, I've gone through the pre-intervention algorithm kind of quickly, but you always end with post-intervention imaging, where the important parameters are number 1, optimal final lumen dimensions, i.e. stent expansion, no geographic miss, no edge plaque burden, or large dissection or a lot of lipid, and no complications. So this is an example that I often show. Notice the Impella device. It was a high-risk PCI, not a bad angiographic result, but by IVUS, the minimal stent area is only slightly bigger than the IVUS catheter because of concentric calcification. This slide summarizes all the literature of predictors of events by IVUS and OCT. Number 1, number 2, and number 3 are under expansion. Number 4 is geographic miss. Everything else is irrelevant. What is a good target MSA? Well, by IVUS, roughly 5.5 is the minimal acceptable stent area that separates events from no events, and that number comes up in just about every study. But if you can go from 5.5 to about 7, you can effectively abolish restenosis in non-left main lesions, and that was also shown in 6 Syntax 2. Most recently with Illumium 4, almost the exact same number. By OCT and MSA of 5.2 and lower, the event rate then skyrockets. Larger than 5.2, almost no events. People worry about stent oversizing, overexpansion, causing adverse outcomes. This is a huge study from the Stanford University Core Laboratory of almost 3,000 lesions, showing that getting a stent area larger than the reference, i.e. stent expansion more than 1, does not increase events during follow-up. We get stents in a box that has a compliance chart. And I often show this and say, okay, assume this is a compliance chart. Assume that you are planting a 3 millimeter stent at 16 atmospheres. What is the minimal stent area that you can expect? And most people say, oh, it's 3, it's 3.24, but the truth is it's only 2.4. And we've done this experiment many times. You get 3/4 of the diameter and 2/3 of the area predicted by the manufacturer's compliance chart. And that's because expansion is not determined by the stent design, it's determined by the plaque into which you implant the stent. In terms of geographic miss, by IVUS we look for a plaque burden of less than 50%. By OCT we look for an arc of lipid less than 180 and a lumen area in the reference adjacent to the stent of more than 4 square millimeters. If you notice, I have not mentioned a word about malapposition. On the left, you see all the literature saying that malapposition has an adverse outcome. On the right, you see all the literature showing that malapposition has no adverse impact on outcomes. The literature overwhelmingly supports the idea that acute stent malapposition is irrelevant, with one exception. Here is the exception. At the proximal edge of a stent, if you have malapposition and you then want to rewire, it's easy to get the wire behind the stent and then deform the stent. So the approach is very simple. You identify the distance from intima to intima, in this case 5 millimeters. You then post-dilate a 5 millimeter balloon at nominal pressure, and you get rid of the malapposition. You don't need high pressures because there's no plaque behind here. I mentioned MSAs in non-stent intervention. This is the classic study from Sujin Kang, published in 2011, and this was based upon angiographic follow-up. Now, more recently, Excel has indicated that a minimal stent area when stenting the left main of 6 in the circumflex, 7 in the LAD, and 10 in the body of the left main. But then back to Assam Medical Center, 5-year clinical follow-up data comes up with an MSA of 12 in the left main, 8 in the LAD, and 6 in the circumflex, and presented at TCT last fall, similar numbers with single stent as opposed to deliberate 2-stent strategies. This is my interpretation of the editorial by Akiko and Sri Bangalore that accompanied the recent paper from Assam Medical Center. These are the historic Sujin-Kong numbers. These are the Excel numbers. And if all possible, these are the optimal minimal stent areas when stenting a left main. If you can't achieve these, what do? You look for some measure of stent expansion. This is from ADAPT DES, and we look for expansion that's at least 40%. And in that study, if you can't achieve an adequate minimal stent area, your next best goal is to achieve a minimal stent area of 40% of the EM area at that particular location. Now, in this slide, I summarized all the literature of the studies with IVUS or OCT guidance and the criteria for post-PCI optimization and how often it is achieved. In general, it's achieved only 50% of the time. Most of the time, or half the time, you don't get the result that you really would like. But even so, if we look at the literature, this is all the literature on imaging guidance implantation of drug-eluting stents. IVUS in white, OCT in blue, and IVUS and OCT in yellow. I'm only going to share with you two of these studies, meta-analyses. This is by Greg Stone, published in The Lancet. And you can see that direct evidence shows that imaging guidance reduces target lesion failure, as well as cardiac death, target vessel MI, target lesion revascularization, stent thrombosis, all-cause mortality, all MI, and target vessel failure, with no real difference between IVUS and OCT. So we now have hard evidence that imaging guidance not only reduces restenosis, but cardiac death and all-cause mortality. And this is another meta-analysis from the UK, where they looked at the number of procedures imaging guided that are necessary to reduce one mortality. And as the syntax score goes up, the number needed to image to reduce mortality actually goes down. This is pooled data from IVUS XPL and Ultimate, showing that imaging guidance reduces cardiac death and cardiac death, MI, or stent thrombosis. And if you achieve optimal implantation criteria, you have an event rate, a mortality rate at 3 years of 0.5%. In a single study from Korea, Renovate Complex PCI, there was a reduction in mortality from 3.8% with angiographic guidance to 1.7% with IVUS guidance at 2 years of follow-up. In most cases, IVUS and OCT can be used interchangeably with equal effectiveness to optimize PCI results, but with a few exceptions. As I showed you, culprits in ACS favors OCT, suspected SCAD favors IVUS, aortoosteal lesions favors IVUS, left main PCI favors IVUS, CTOs favor IVUS, stent failures favor OCT, and chronic renal insufficiency, in order to eliminate contrast, favors IVUS. So this is my last slide. It takes the viewpoint that the most central imaging modality in the cath lab is not the angiogram, it's intravascular imaging, because it is useful in every aspect of a PCI procedure, from diagnosis to pre-PCI planning to stent optimization to minimizing contrast and to assessing stent failure at follow-up. Thank you for your attention.